within the hierarchical classification of histotypes. The numbers in these groups will getting smaller, and then collaborative research is required. Let me show some examples. For high-grade serous carcinoma, Totel and the TCGA proposed 4 molecular subtypes by mRNA expression profiling. This recent work here now created a consensus molecular subtypes based on a robust nanostring platform. To me, this is an example of the highest scientific standards and how the ovarian cancer research community can reach consensus with avoiding the chaos we see in other fields. However, a similar stratification can be achieved by a simple IHC stain, and this is a quantification of tumor-infiltrating lymphocytes by CD8. While there's biologic information in the molecular subtype, another approach is shown in this study, where 101 gene signature, also assessed on the nanostring platform, was to use to optimize against outcome. And a more continuous stratification in quintiles is shown here with a remarkable difference in 5-year survival. While mRNA expression profiling assesses mostly the microenvironment, it's interesting to note that tumor intrinsic factors in this study from David Botel's group showed the combination of HRD with RB1 was enriched in long-term survivors, and even in a subset of exceptional responders, which are characterized by long progression-free survival, this combination predicted a higher chance of survival. Continuing with tumor intrinsic features, an elegant study by James Brandon showed the bewildering complexity of copy number signatures shown represented here by stacked bar plots for each patient. High-grade serous carcinomas are a high entropy disease based on a copy number level. Saurabh Shah's group took another approach and divided high-grade serous carcinoma by the main mechanism into chromosomal instability with HRD high and fold-back inversion FBI high. The HRD BRCA mutated cases are now considered for PARP, which is great, but we also need to turn our attention to the FBI high group, which is lead alteration, which is high-level cyclin E1 amplification, and this is associated with a dismal long-term survival. Adapted from a the minimal standard of current testing is somatic and germline BRCA testing. I just want to point out, if modern histotyping is applied, BRCA alterations are confined to high-grade serous carcinoma. One example is shown here on the right. I was asked to confirm clear cell carcinoma type in this study, and by applying the 4-marker IHC panel on tissue microresection, I assessed that some tumors are more likely high-grade serous carcinoma and not clear cell, which was consistent with later genomic analysis, which showed that the BRCA mutation in these tumors were actually in the misclassified or reclassified high-grade serous carcinoma. This recent study on low-grade serous carcinoma, I believe, shows that there are at least 5 molecular subtypes in low-grade serous carcinoma emerging, which are associated with higher risk of death. First one is alteration in CDKN2A or P16, PR loss combined with high fraction of the genome altered, a group with MAP kinase mutation, a group with a newly discovered ubiquitinase mutation, and a group with no specific molecular alteration. For endometrioid carcinomas, there are the same molecular subtypes in ovarian endometrioid carcinoma as have been shown for the endometrioid counterparts. In this study, molecular subtype shows a better stratification than grade, and that was most apparent in the low stage setting. The irony is that this was the first study to validate grade as an independent prognostic factor within ovarian endometrioid carcinoma, and at the same time bringing grade to its deserved resting place within ovarian carcinoma by showing that there's no use in the setting of low stage while molecular subtype has. The question is now how to tie PR, which is a strong prognostic factor and a possible predictive marker, into this molecular subtype. If modern histotyping is applied, MMR deficiency is confined to endometrioid carcinoma. In conclusion, histotype classification is now based on an integration of objective IHC markers, and histotype-specific genetic and predictive testing should be performed. So that means high-grade serous carcinoma should be tested for BRCA1 and endometrioid carcinoma for mismatch repair deficiency. This has also important implication for the inclusion for histotype-specific clinical trials, and emerging molecular subtypes require multiple technologies. Thank you.
Thank you, Dr. Kobel. That was a wonderful introduction to this session. We will now move on to the next segment regarding ovarian cancer surgery. And Dr. Sven Mahner will begin this session with an update on the TRUST trial. Please go ahead and begin your presentation.
Thanks, Doug, for the introduction, and thanks everybody from the program committee to putting up TRUST and an update on the TRUST study on this year's schedule and program. And let's start with my disclosures, which are listed here. The TRUST study, I think, is a study that most of you might be familiar with. It's another approach to try to answer the question, what is the best for our patients with advanced ovarian cancer, upfront surgery or interval debulking surgery? And the first third of today's session will actually circle around this debate. And after my update on the TRUST study, there's going to be a pro and con session on upfront or interval debulking surgery. So I will just try to lay the stage for the discussants coming after me. The TRUST study was a very, very close and intensive international collaboration of different study groups, different countries, and also single centers that we started after the two previous phase 3 studies that addressed the question did not yield so many results or so conclusive results that we could definitely address and answer the question. So the design of the TRUST study was therefore pretty similar to the two previous studies. So patients with advanced ovarian cancer could be included into this study. One important aspect regarding patient selection in this study was that the patients had to have suspected advanced ovarian cancer, and the experienced ovarian cancer surgeon had to estimate that this patient could potentially undergo complete resection. So we excluded patients where we initially could be sure that those patients were not candidates for complete surgical resection. The reason might be either the pattern of tumor growth or the overall condition of the patient that made extensive ovarian cancer surgery not feasible. So all those patients that could potentially be resected were then randomized and underwent either upfront debulking surgery and a subsequent systemic treatment according to current standards with addition of bevacizumab, PARP inhibitors, whatever is the standard in the different countries. We did not try to have a medical or a conservative treatment study comparing different chemotherapy regimens, but rather the different surgical approaches in the study. And in the second arm, patients underwent interval debulking surgery. And an important difference to the previous studies is that it was mandatory to first have a tissue biopsy on these patients. So cytologically proven ovarian cancer was not allowed, but we had to have a history, and this is also an important aspect of the translational research projects that I'm going to come to later in this presentation. So that's the pretty straightforward design of the study. And I said that we had quite a low bar for patients to enter the study. Potentially completely resectable ovarian cancer was the only criteria for a patient to get in. However, for the participating centers, the bar was quite high regarding the number of procedures performed in the different institutions, the amount of complete resections in ovarian cancer. So we wanted to select, on the one hand, as many patients as possible and most representative patient population we could get, and on the other hand, have only high volume, high quality centers, and did actually quite an extensive quality assurance program. And this was the hard part with T and also with D in the spelling for the TRUST study, for the centers to participate, and also for the quality control, quality assurance program during the study. So with this approach, we selected a few handfuls of centers all over Europe and also one in the UK. And one in the US, which did not fit on this map. So that's why it's located here in the middle of the ocean. And but the representative from this center is also actually in today's session. It's Dennis Chi. So hello to Dennis, and thanks for participating here. And sorry for putting you in the water here. And with the joint effort of these centers, we were able to recruit and randomize almost 800 patients over a little bit over a year. So quite successful patient recruitment in this study, and recruitment finished in summer of last year. And currently we are waiting for the results regarding the primary endpoint of the study, which is overall survival. I think the only viable endpoint for such a study approach and such a question. And this is expected to be ready by 2024. However, we will see if that's the case. And it depends, of course, on the number of events. And there's, of course, a few secondary endpoints that are listed here, and also many exploratory and translational projects that we address together with this surgical study that I would like to highlight over the next few minutes and put your attention to, because I think a surgical study like this gives the unique opportunity to also collect specimens for translational research and perform different translational research projects in such a setting. And if you look at the two different arms, we collected for this TRUST translational project tissue as well as blood samples. And in the primary debiking arm, we collected blood prior to the surgery, prior to the start of chemotherapy, and at the end of chemotherapy. And tissue, there was, of course, only one time that we were able to collect tissue during the primary surgery. In the interval debiking arm, however, we had the opportunity for half of those 800 patients to collect tissue at the biopsy after randomization before starting of chemotherapy, and then again blood samples prior to start of chemotherapy, prior to debiking surgery, and after the end of chemotherapy in this concept. Currently, we are in the phase while recruitment of the patients is finished and we are waiting for the primary endpoint of overall survival. We are getting together all the tissues from the participating centers. So if we want to wrap up the current status of the study, the most important point at this moment is that tissue collection is still ongoing until the end of this year. We have a couple of hundred patients already registered for the translational project and tissue collected, but I'm sure in the audience, at least one representative of each participating center of the TRUST study is present at the moment. So to those of you who already sent the samples, thanks a lot. And to those of you who are still planning to send the samples, please hurry up. And if there's any questions regarding the translational project, don't hesitate to contact me personally or our study staff in order to get as many samples for this project as possible, so we can hopefully not only answer the question, what is the right timing for surgery in patients with advanced ovarian cancer, but also answer the question if we can, for example, predict resectability of ovarian cancer in a certain subpopulation of patients. There's very interesting previous analysis on this, but not in the cohort like we have in a TRUST study. We are looking for specific tumor aspects regarding the response to chemotherapy, which is also possible in this unique setting of tissue samples collected prior to neoadjuvant chemotherapy and then at interval debiking surgery. And of course, we are very open for additional projects. So if there's anybody in the audience that has some good ideas, what else should be done in this translational research project, you're all very welcome to come up with any ideas and send your proposals, and we are happy to discuss and hopefully include them in our project. So that's so far the update on the TRUST study, and I would like to end by thanking everybody who participated in the study, patients, of course, but especially also the surgeons. This was not an easy task to finish this study, and the speed of recruitment and the dedication of the participating sites and surgeons cannot be thanked enough. So it was really a great success already to completely recruit that study, and this would not have been possible without the surgeons, the research staff, and the patients. And so I'm looking forward to the results of the study, and I'm looking very much forward to the upcoming debate on the pros and cons on upfront or interval debulking surgery, given the currently available data of phase 3 studies and what else we know about advanced ovarian cancer surgery.
Great. Thank you, Dr. Mana. That was another wonderful presentation. Exciting results coming in a couple of years. Please feel free to send in your questions to any of the participants. We will have a discussion in a short while, and we'll get to all the questions for all the presenters at that time. At this point, would like to have Dr. Anna Fagotti, who will present a component of the neoadjuvant approach to surgical cytoreduction and newly diagnosed patients, and Dr. Rob Coleman will conduct this interview with her. Thank you, folks. Take it away.
Thanks so much, Doug, and congratulations, Dr. Manner, on completing TRUST. I think you set the backdrop for this next series of discussions, looking at the pro cons for neoadjuvant chemotherapy based on available data, and it basically sets up the whole point of why we're doing that, why you guys did that trial. So I'm going to ask Anna to address these 5 questions in her talk. So first of all, like, who are the right patients? What algorithm is maybe chosen to triage patients neoadjuvant? Are there prognostic factors that we need to pay attention to when we look at this cohort of patients? As Dr. Manner just mentioned, are there molecular characteristics that can help not only predict the response to neoadjuvant chemotherapy, but ultimately whether or not there's the emergence of chemoresistance? And so Anna, I'll ask you to take it away and address these questions.
Thank you very much, and thank you everyone for this invitation. These are my disclosures. So let's start. Results based on this excellent review on randomized data evaluating adjuvant chemotherapy versus primary debulking surgery show that all these studies, besides their own limitations, which have been extensively discussed before, show that neoadjuvant chemotherapy is not superior or not inferior to primary debulking surgery. Moreover, all these studies also agree that the rate of major postoperative complications is higher in primary debulking surgery versus neoadjuvant chemotherapy followed by Igcs. So in principle, we may state that each patient is a possible candidate for neoadjuvant chemotherapy if with advanced ovarian cancer. However, the use of neoadjuvant chemotherapy is largely accepted in frail and elderly patients. And the reason is double. On one side, we want to reduce the tumor burden with the aim to reduce the number of multivisceral resection needed to achieve complete cytoreduction. And on the other hand, we want to reduce morbidity and mortality due to the combination of extensive surgery together with comorbidities related to age. And therefore, we want to make surgery an option even for those patients who are unfit for surgery. And as you can see in the slide on the right side, you see that elderly patients have a higher residual tumor after surgery with lower surgical complexity score, which means that probably we use inadequate surgery for these patients. Therefore, probably modification to the sequence of treatments administered with priority given to neoadjuvant chemotherapy may assure these patients to achieve complete cytoreduction and then complete treatment and definitively longer survival. However, there are some patients who are not frail, they are not elderly, they are fit, they are young, they are supposed to be resectable, but in fact they are not. And so we, in our department, use laparoscopy before deciding whether or not managing these patients to primary or neoadjuvant chemotherapy. And this is the algorithm that we use, staging laparoscopy. First, we assess for the presence of small bowel carcinomatosis or mesenteral root retraction. Indeed, in our experience, we showed that these are the main limitations to achieve complete resection. Then we assess, of course, diffusion of disease, including presence of peritoneal carcinomatosis, diaphragmatic carcinomatosis. We assess the disease in the upper left quadrant, spleen, lesser sac and stomach, superficial liver metastasis, omental cake, and the need of bowel resection except for anterior rectal resection. We have published some papers where we describe how to properly assess the positivity or negativity of these variables during laparoscopy. And we use laparoscopy also to assess the risk of perioperative complications using a very simple score, including some simple variables such as ECOG performance status, ascites, CA125, and tumor load. And as you can see here, each variable has a different score, and the score is made based on the odds ratio with respect to the risk of having postoperative complications. So here, at least in our institution, if the score is higher than 10 and the risk of perioperative complication is higher than 30%, including major perioperative complications, of course, we prefer to use neoadjuvant chemotherapy. Now, what is the most important prognostic factor in patients receiving neoadjuvant chemotherapy? As you can see here, these are 11 studies, including more than 2,000 patients with advanced ovarian cancer receiving neoadjuvant chemotherapy. And you see very clearly that patients receiving optimal cytoreductive surgery have a longer survival with respect to those patients who received suboptimal cytoreductive surgery, and especially those who achieved no gross residual disease had a better survival. And the same is shown on the right side from a large series from French authors. Residual disease at the end of interval debulking surgery is a very important prognostic factor. Now, on this background, what we try to understand is whether patients achieving optimal cytoreductive surgery with a residual tumor between 1 and 10 millimeters have actually the same or better survival with respect to those patients receiving no gross residual disease at time of interval debulking surgery after neoadjuvant chemotherapy. And as you can see here from our series, there is no difference between these two groups at time with respect to progression-free survival. There is actually a difference in terms of overall survival in favor of the neoadjuvant group, but of course here is a limitation given to the bias of selection. Indeed, patients receiving no gross residual disease at time of interval debulking surgery are those patients who responded to neoadjuvant chemotherapy. Therefore, we are comparing different groups, and actually it's not a good comparison. Of course, if we might have some predictive marker to predict response to neoadjuvant chemotherapy, then in that case, it would be nice to manage those patients who are going to respond to neoadjuvant chemotherapy and then successful interval debulking surgery. There is a growing body of evidence showing that BRCA carriers show a higher benefit of platinum-based neoadjuvant chemotherapy compared with BRCA wild type in terms of clinical and pathological response, as you can see here. Mutation carriers have a 34% of complete clinical response with respect to 4% of mutation non-carriers, and the same regards histopathologic response, 46 versus 24%. And also, in our series on around 456 patients who were tested for BRCA somatic mutations, you can see that among those cases who received neoadjuvant chemotherapy, those who did not achieve interval debulking surgery for stable or progressive disease had mainly a wild type BRCA status with 92.6% versus 7.4%. Now, the last point is neoadjuvant chemotherapy able to induce any kind of chemoresistance with respect, of course, to primary debulking surgery? Now, this is our series. We performed a retrospective analysis of 175 patients, stage 3 and 4 ovarian cancer. These cases were matched for 3 different variables: high tumor load at time of diagnosis as assessed by our staging laparoscopy, complete tumor resection either at PDS or interval debulking surgery, and at least 24 months of follow-up. And as you can see here, we were able to demonstrate a better behavior of recurrent disease in advanced ovarian cancer patients receiving primary debulking surgery with respect to neoadjuvant group. In particular, the primary debulking surgery group had lower recurrence rate, had a different type of recurrence, mainly single or discrete lesions with respect to carcinomatosis. They had a longer progression-free survival, and also the treatment options offered at time of recurrence were different, where more secondary cytoreductive surgery were offered to the primary debulking surgery group. However, I think that the most important consideration is to find a reason or a molecular explanation to this type of chemoresistant. And this is a study made by some colleagues in Russia, where they did an assessment of BRCA status in tumor pairs pre and post neoadjuvant chemotherapy. And as you can see here, they were able to demonstrate that there was a restoration of BRCA1 heterozygosis after neoadjuvant chemotherapy. And this restoration was not related to reversal mutation in the gene, but however to the selection of BRCA1 proficient clones that were already present in the tumor itself, but they have been selected due to the pressure from platinum compounds. So having said that, the point is, what is the clinical impact of this finding on our clinical behavior or clinical decision making? So we know that loss of heterozygosity in BRCA mutated patients means that they are more susceptible to a more very good respondent to platinum compounds. And on the other side, we may argue that these patients who restore their heterozygosity, maybe they may call for alternative treatment options after interval debulking surgery. So in conclusion, I would say that neoadjuvant chemotherapy is a valuable option to decrease perioperative morbidity in frail, elderly, advanced ovarian cancer patients, or those with high tumor load. That residual tumor still is the most important prognostic factor at time of interval debulking surgery, that molecular factors predicting response to neoadjuvant chemotherapy are emerging, and neoadjuvant chemotherapy may select resistant clones to standard chemotherapy. Thank you.
Great. Thank you very much for that wonderful presentation. Up next, we have Dr. Dennis Chi presenting the primary debulking surgery component, and Dr. Nicoletta Colombo will serve as the interviewer. So folks, please take it away.
Hi, hi everyone. So Dennis, I have a lot of questions for you. I would like just to start by asking this important question. Given that there are published prospective randomized trials that have shown no difference in survival for primary debulking surgery versus neoadjuvant, but more morbidity for primary debulking surgery, why are you still a proponent of primary debulking surgery?
Hello, everybody. I guess I'll just load up my slides to answer those questions. I kind of knew this was going to happen.
Just hit the little icon at the bottom there, Dennis. Yeah, right there. Oh, you passed over it. Yeah, that one. There you go.
Oh. So thanks to Doug, Nicoletta, and Rob. I thought I was just going to answer questions without slides, but then we decided to have slides, and I thought I was just going to go back and forth with Nicoletta. But Nicoletta, please interrupt me if there are questions and you want me to stop. But
Sure.
I was asked to talk about the PDS proponent, and I will answer Nicoletta's questions. Here's my disclosures. And I know Sven, my good friend Sven, I was going to put a picture of the ocean behind my background because Sven has me now somewhere in the Atlantic Ocean, but I'm in New Jersey. talking from my home. And I was, yes, Memorial Sloan Kettering did participate in the TRUST study. And he alluded to the fact that this was going to be a debate. And yes, myself and many of the people in the audience and on this panel have had these debates about primary debulking versus neoadjuvant chemotherapy. And for the sake of debates, we're always told by the organizers, try to be very aggressive. And if you're on the neoadjuvant side, try to say that 100% of patients should have neoadjuvant chemotherapy, and dentists, make it seem like 100% of patients in your institution don't undergo primary debulking. But my buddies in the Axis of Evil, Rob Bristow, Bill Clyby, would kind of say, no, probably the truth is somewhere in between, that us proponents of primary debulking ourselves don't do primary debulking on 100% of patients. And it's more on the order of 60 to 90%. And we do use neoadjuvant chemotherapy, but I guess as Nicoletta alluded to, in selected cases. We are proponents of primary debulking at Memorial Sloan Kettering, and we would try to debulk unless there's a good reason not to. So looking at the randomized trials, I've shown these slides before. I think everybody knows, so I'm not going to spend a lot of time on them. But the idea of the randomized trials, aren't we supposed to practice medicine based on level 1 evidence? Well, the problem with the first 2 randomized trials was, if we are to believe that complete gross resection is the goal of primary debulking surgery, then less than 1 out of 5 patients got the assigned treatment. As I say many times when I give this talk, opening up somebody's abdomen and exposing it to air is not therapeutic. So less than 1 out of 5 patients got the assigned treatment. And also, as we'll talk about a little bit more, in these cases, maybe it was this case selection of maybe sick or very extensive disease. In the primary debulking's arm, the perioperative deaths were a little bit on the high side, if you ask me. And then in looking at the Japanese study and Anna's study, I have a world of respect and admiration for Anna. And so nothing against her personally, but I do believe that they were also operating on patients with very high tumor load and maybe some personal medical morbidity. And from what I gathered from the paper, the number of perioperative deaths was kind of on the high side. Maybe this has been modified on the article, which I wasn't able to access last night. I think we can all agree, let's find some areas where there's common ground. We can all agree that whether you're going to do a complete, primary cytoreduction or an interval cytoreduction, complete debulking of all gross residual disease is the goal of surgery. So this was a meta-analysis by Chang from South Korea, where he showed that basically the higher the rate of complete cytoreduction, the better the median overall survival will be. And this has been a project that we've been working on at Memorial Sloan Kettering for decades. When Dr. Levine was a fellow through to his time through to now, that as time goes on, we are working harder and harder to get our complete gross resection rate up. And this isn't even the most recent data, but our data from 2010 to 2013 shows that you can have extremely high survival of close to 6 years if you are able to completely grossly resect 50% or more of these patients. And I'll show you that we're in this area now with the complete gross resection, but obviously we don't have that overall survival just yet. So there have been multiple studies from Nicoletta's group, from the Mayo Clinic, from South Korea, from Memorial Sloan Kettering, that have shown that if you improve your surgical outcomes, improve your complete cytoreduction rates, you will improve your median overall survival. However, this study out of Sweden was just published this year and showed that when they changed their paradigm to include upper abdominal surgical procedures, they did not improve their median overall survivals. And as a matter of fact, those patients who had extensive surgeries didn't do quite as well as we would have predicted based on prior studies. But this is just one study. And I think the problem is that, as C. Paul Morrow said, the shortest survival is a perioperative death. So again, patient selection is very, very important when you're deciding on whether to do primary debulking or neoadjuvant chemotherapy. Should everybody then therefore undergo universal laparoscopy? I think it's a great tool. And I would like to say that nobody should have laparoscopy, but as you'll you'll see from our own data, we do believe laparoscopy should be used in these cases. The problems are you can miss disease, especially in the retroperitoneum, if you only use laparoscopy. So CT scan is important in that area. It can overestimate the extent of disease, and you can think you have small bowel carcinomatosis over the whole area.
Dennis, can I stop you for a minute?
Sure.
I want first, you're now moving to the selection criteria. I want just to go back to the question about randomized trial showing no improvement in survival, but less morbidity. So if I go to, I mean, these were scientific explanation, but if you go to a patient side, so which argument would you use for a patient who comes to you and says, Dr. Chi, you are a wonderful surgeon, and you are proposing me this aggressive procedure with a lot of possible complications, but my neighbor with a similar diagnosis just got 3 cycles of chemotherapy and then not even an open surgery, but she underwent a laparoscopy, a robotic surgery with 4 small holes and no complications. She's doing perfectly fine. So why should I go through a devastating surgical procedure instead? What would you tell this patient?
Well, I would tell the patient, I think that's a great point, and I think that the way that you can have no surgical complications, this is an exaggeration, the way to have no surgical complications is not to operate. The way to have less surgical complications is to do a laparoscopic biopsy. The way to have a little bit more complications but do a little more is to do a laparoscopic hysterectomy and ometectomy. The way to have a little bit more complications is do a laparotomy, et cetera, et cetera. So the point of what we've been doing for the past 20 years is that you can do surgery, and if your metric is surgical complications, then less is definitely better and less is definitely more. But the problem is if you do that and you don't do the surgery now, you're going to, or don't do the primary debulking to a complete resection, you're going to pay later. And that's why I didn't have the time to put in the slides. There are no studies that I know of that have done neoadjuvant chemotherapy in advanced ovarian cancer patients and show median survivals over 60 months or so, or even 50 months. Most show median survivals in the 40-month range. So sure, you don't have to have a big incision, you don't have to risk the complications, but in the end, almost every single study that I know of that has looked at primary debulking surgery in institutions like Sven has included in the TRUST study have shown median overall survivals of over 50 months for all comers, including ours. And that's why I showed that one meta-analysis by Chang, and basically the long median overall survivals, yes, it's due to a little bit of patient selection, but it's due to the fact that you're doing the surgery first when you still have 6 cycles of postoperative chemotherapy, rather than using 3 cycles of chemotherapy to shrink the tumor and make the surgery less morbid and less extensive.
Okay, so going to the selection criteria, since we have only a few minutes, I want just to ask you direct questions about the selection criteria. First
Sure.
of all, do you use a frailty score, and which one, if you do? The second question is, do you use a pre-habilitation program for patients who are frail before surgery, before primary debulking? Well, just answer to that.
Can you say the first question again?
Yeah, I mean, do you use a frailty score to assess the patient status before going into primary debulking surgery? And which one do you use? Or you look just at performance status, age, comorbidities, and so on, but you put them together in a frailty score or not? Or
so we use the Mayo Clinic has published a lot of papers on this, yeah. And we use the paper. We participated in the paper by where Aleti was the lead author, who works with you. And yeah. Basically, the Mayo Clinic has published now at least 3 papers on this, where they use to determine whether somebody's a candidate for surgery. They use a combination of age, the extent of disease, and essentially the frailty of the ASA. A big factor in the Mayo Clinic data is to use serum albumin. So in the
Okay,
most recent
so
paper,
you use those criteria from Mayo Clinic, basically.
we used the first criteria from Moletti that we participated in way back in 2010. And yes, our postoperative mortality is less than 1%. And I think that plays a major role in why our patients are able to do well.
Yeah. So now this is the patient side. So in terms of tumor resectability, if you have a pleural effusion, do you perform VATS and always, or when?
Yes, we do. So in a patient who has a pleural effusion, we have found that we find solid tumor 60% of the time in the chest. And the patients who have gone on, before we had complete gross resection, as the goal, we used to do primary debulking, even if there was disease less than 1 centimeter in the chest. And we're about to publish a paper, it was just accepted by G1 Oncology, of the first 100 patients. And the bottom line in that paper is that if you had gross residual disease in the chest, it didn't matter what you did in the abdomen, those patients' survival was under 40 months or so. If they had no disease in the chest and you completely grossly resected the chest and the abdomen, those patients had median survivals in the 70-month range.
Okay, so if it is resectable outside the abdomen, you do, even though it's not in the abdomen. If it's not resectable but small, I'm talking about diaphragmatic disease, but very small, you still go ahead with abdominal debulking.
Well, that's what we used to do. Now, based on our recent data, if we cannot clear the chest, we don't operate on the abdomen.
Even though the disease is very small in the chest.
Correct.
Yeah, you don't.
That's been a change. That's something that we changed just based on this recent data.
Yeah. So basically, you believe that stage 4 disease is a bad prognostic factor, but you can rescue this prognosis by doing debulking surgery when it is feasible, even outside the abdomen. Is that your point?
We published a paper that showed that if you have supradiaphragmatic lymph nodes and you resect them, we had a median survival over 80 months.
So you rescue stage 4 to stage 3, kind of. I mean, you just, that's what you are saying. Okay. So the last question, because we're over, 20 years after the paradigm shift towards aggressive primary debulking surgery, and still, in the majority of clinical trials, even presented yesterday, the percentage of optimal cytoreduction remains 30%. So why? Why? Because we still have serious doubts about the possibility or the prognostic factors, or because there's a lack of expertise and a lack of dedicated centers capable of performing this surgery.
Yeah, I think it's multifactorial. It's do the surgeons want to operate for 6 to 8 hours? I have back pain, I have neck pain, I have foot pain. Is the institution willing? I've heard this from institutions in Canada. Dennis, what you do is great, but there's no way I can do 6 to 8 hours of theater time and do one case when the hospital wants me to do 3 endometrial cancer cases. I think it's a multifactorial problem. I guess I have to be honest, and the benefit of Memorial Sloan Kettering is that the infrastructure and the philosophy there is, yes, don't back out and try to do the most that you can surgically. But again, we have pretty good results because of the collaboration with other surgical services and the philosophy that we're gonna do what we can to get it all out.
Thank you very much. I think we are over our time, so
totally great. Thank you.
Thank you for the discussion.
Great. Thank you both for that wonderful interview and a beautiful interview format. We have a number of questions, so I might ask all of the presenters for this session to come back online and the moderators, interviewers, because we can have a collaborative discussion here. Since we just heard from Dr. Chi, maybe just a few simple questions for Dr. Chi. We have about 10 minutes or so for questions. For the 261 attendees, please feel free to send your questions in